My name is Beth Carter. I'm an epidemiologist in the Public Policy Institute at AARP. And in your folder, you'll find a report that I recently wrote. The title is Off-Label Antipsychotic Use in Older Adults with Dementia, Not Just a Nursing Home Problem. So I know the focus today is on nursing homes, but I wanted to follow up on some data and reports that the GAO and CMS had conducted in 2015. So GAO in January of 2015 released this report. I encourage you all to read it, which found that about 30 to 33% of nursing home residents were taking antipsychotics in 2012, and about 14% of older adults with dementia who were not living in nursing homes, who were, quote, community only, were on antipsychotic drugs. And then CMS replicated these results, and later that same year, in 2015, produced this report in which they found almost identical results to the GAO study. Now, these studies are on Medicare enrollees, the fee-for-service enrollees 65 and older. So they found 15% usage of antipsychotics in community-only adults. And let me just define what community-only is. Basically, an adult living in any setting other than a nursing home. So that can include assisted living or group homes. So since then, there's been, let me just skip to this slide. Since then, there's been updated numbers on the use of antipsychotics in nursing homes. And what appears to be great news, a drop of at least over 30% from beginning of 2012 to beginning of 2016. Now, I think there are some things to keep in mind here. 3 things. One is dementia patients who might be put on antipsychotics are, I hear that nursing homes are less likely to accept them. So they realize there's a problem. Patients who maybe have behavioral symptoms, the nursing home may not accept. So that would help these antipsychotic rates go down. Another is antipsychotics are indicated for the treatment of bipolar, schizophrenia, Tourette's, and Huntington's disease. And I've heard from some physicians that they themselves are not doing this practice, but to add one of those diagnoses to the patient's chart, which then makes the usage of the antipsychotic appropriate and doesn't fall into this category of inappropriate use. And the last is nursing homes may be switching from antipsychotics to other mood-stabilizing drugs, which then would help this rate reduce. So, there is great news that there's this 30% increase. I think more research needs to go into why this is decreasing. So then I decided to replicate the GAO and CMS results with data I have access to, the Optum Labs data warehouse. And so my study was conducted on Medicare Advantage enrollees 65 and older. And I found a use rate in 2012 of 12.6%, which is slightly lower, but pretty much in line with the GAO and CMS analyses. The rate was higher among females and among the older adults, and also highest in the South Census region. But I was interested in seeing what was happening over time with these results among community-only patients with dementia, and I found that there's been a 6% increase since 2012, between 2012 and 2015, of the use of these drugs. Again, I wouldn't be a good epidemiologist if I didn't point out the limitations to my study. There are about 30,000 adults in each of these years, compared to the GAO and CMS analyses, which had close to 1 million. So I have a smaller sample, and it's just among Medicare Advantage enrollees. However, this is a significant increase of 6%, and much of at least 99% of my sample was living at home, either in their own homes or with relatives. Less than 1% was living in an assisted living facility. So this is mainly happening in the home environment. So I think Oh, I was on the phone with a reporter yesterday from the Kansas City Star, and he said nursing homes are going to be really excited to see this report because they say that patients are coming to the nursing home already on the antipsychotics, so this is just substantiating what they're saying. And so I just want you to keep that in mind, that to nursing homes, this may be good news. So for the next steps, it's imperative to reduce the antipsychotic use among community-dwelling adults before they get to nursing homes, and to stop it where it starts. In the GAO report, they recommended that Health and Human Services expand its outreach and educational efforts to reduce antipsychotics outside of the nursing homes, including updating the National Alzheimer's Plan, and we are definitely on board with that recommendation. I think future research of community-only adults with dementia should split up those living at home and in assisted living so we can really crack down on what's happening in the assisted living communities as well. And then, as you all know, and you've heard today, the evidence-based interventions for older adults with dementia are mostly behavioral interventions that are being underused at the moment.
Hi everyone, I'm Sarah Locke. I'm the Senior Vice President for Policy at AARP and the Executive Council of the Global Council on Brain Health. It is my pleasure to be with you today here and thank Kelly and Mom for the invitation and for the incredible work that they have been doing along with AARP Foundation with Bill Rivera to tackle these incredibly difficult cases, difficult for a whole lot of reasons, the medical issues, the emotional issues, the family issues, the financial issues, and thanks to the AARP Foundation for supporting this incredibly important work. And actually, I'm a little biased. I came to AARP through the foundation, and many of you who are in this audience, I've had the great pleasure of working with you over my career because of it, and it's great to see you here and know that we're still fighting the fight, but we're starting to make some progress. And I know some of these things look overwhelming, and so I've been thinking about trying to figure out how we can talk about reframing them. And taking a look at Beth's study, we've identified the problem. We know what the problem is. So what are we going to do about it? And I think that there are three things that we're going to need to do about it. We need to choose better treatments. We need to train people, and I mean caregivers, family caregivers, and professional caregivers, the healthcare treatment, the healthcare providers. Train them to do better. And we need to pay for it. So we need to choose, train, and pay. And when I talk about paying for it, I think we have evidence already that by implementing these better treatments, we can actually save money. We just need to tell this story, and we need to find ways. Jonathan has obviously incredibly persuasively been looking at how to change the minds of healthcare providers. But we have to find ways to do it systemically, and I'm hoping that all of us in this room can do this. So the topic that I was asked to speak about is specifically research and thinking about the future. So I want to talk to you a little bit about some of the research that is out there targeted to healthcare providers, things that we know work. That Malaz Bustani's work in Indiana is fantastic interventions that we have already seen save money, improves care. The UCLA work, David Rubin in UCLA, saves money and improves care. For individuals, we have research that's been evaluated, and I'm going to put in a plug for my colleague Lynn Feinberg's work, From Research to Standard Practice, Advancing Proven Programs to Support Family Caregivers of Persons Living with Dementia. We know that these are incredibly challenging behaviors that people are exhibiting, and they're crying out. But we know that there are good interventions that can handle and help the 90% of people living with dementia who experience these symptoms. we can move from unhelpful and even dangerous treatment because, as Jonathan said, we have to change people's beliefs. And it's a systemic issue because 25% of people who have dementia, living either in nursing homes or at home, experience preventable hospitalizations. In 2013, if we could change that and prevent those unnecessary hospitalizations, much of which I would argue is caused by the inappropriate use of these medications, causing people to fall and have uncontrollable symptoms, Medicare would have saved $2.6 billion in 2013 alone. It would save individual caregivers $216 billion that they spend, and the $44 million out of pocket that they spend. And we know this because, not necessarily because of the work that we have done in this room, but some of the researchers like Helen Kales and Laura Gitlin and Konstantin, I'm going to butcher his name, George is how I know him, have shown us about these interventions. But why aren't they being picked up? And why I'm particularly hopeful on this topic is that coming out of the NAPA Advisory Council work, the NIH sponsored a research summit on improving dementia care. And the report is about to come out, but there were 500 recommendations made by a group over 2 days. And this was a 1.5 year long body of work to try to address some of these issues. And why was it that this was the first time that NIH was having a research summit on improving care and treatment? They've had 3 or 4 on prescription drugs. It's because the cost incentives that are inherent in the system are encouraging the drug companies to come forward and find cures because there's a huge upside potential in it. But finding the upside potential and changing the cost conversations around improving care and treatment for treatments we know work better just isn't being had. So we have to figure out how to change those financial incentives and make those arguments compelling so that our leaders who all want to do the right thing have the ammunition they need. So what are those better symptoms or better treatments that work more effectively that we're talking about? Dr. Evans talked about it, looking for the triggers for the symptoms, manage and remove those triggers, and prepare caregivers, both professional and non-professionals, to deal with them. What are some of those therapies? I have a whole little card full of them. Music therapy, aromatherapy, occupational therapy, bright light therapy, therapeutic touch like massage, reminiscence therapy, validation therapy, pet therapy, meaningful activity therapy. All of these kinds of interventions have shown beneficial effect with respect to agitation and anxiety. We even have useful interventions for preventing and helping hallucinations and delusions. So I only have 1 minute left, and so I'm going to try to see if I can try a metaphor out on you and see if you guys think this works. I've been thinking about the different kinds of research out there trying to solve the problems that we have spent our careers trying to solve. And if you think about the cure research, that's what I think of as Dudley Do-Right, and we're all Dudley Do-Right here, trying to save Nell from this terrible disease of dementia. If I think about the research that's out there to stop the train from coming down the track, that's the cure research. If I stop and think about the research about trying to prevent Nell from getting on the tracks in the first place, that's the prevention research. What we're talking about is getting Nell from stopping her from being tied to the tracks, right? These restraints that we're using. We have to figure out how to empower the care providers to untie those ropes and help her up off those tracks. And if we can, as a collective body, think about that as our mission, that from the research we have the power, we just need to figure out how we're all going to untie Nell, I think we are going to be able to solve a huge problem. And I hope that we will do that together. Thanks.